As we move towards recovery and rebuilding following the COVID-19 pandemic, we're guided by the lessons we've learned, which include demonstrating innovation and filling gaps in our local system of delivery and models of care. The intent is to bolster the infrastructure of care delivery as well as the health of our communities. We know rural communities have been rocked by lost services and hospital closures, yet change is taking place in rural America, where healthcare leaders are actively transforming their organizations. Strategic partnerships that cut across the care continuum are enabling rural providers to provide access and advance the health of their communities. Success is being driven by inspired leadership, forward-thinking governance, and resilient clinicians and staff. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hedderly, Executive Speechwriter for AHA. Now more than ever, strong connections between rural health leaders are critical. As rural hospitals embark on a path towards recovery, we are left to reflect on what has transpired and how to guarantee access to care for the 20% of Americans living in rural communities.
Good day. I'm John Supplett, Senior Director of Rural Health Services for the American Hospital Association. More than half of women in rural communities don't have access to local hospital obstetrical care, increasing the risk of poor health outcomes. Despite these increased risks, rural maternity units continue to close. Today, we'll hear part 2 of the story on a pathway to recovery from rural North Carolina. Chatham Hospital, part of the UNC Health System, is a 25-bed critical access hospital located in Siler City. Until 1991, the hospital had a maternity care unit. However, as is in the case of many small rural hospitals, local obstetricians discontinued services and the maternity unit closed, leaving the entire county without any obstetrical services. With support from the UNC Health, Chatham Hospital has rebuilt its maternity care unit, providing care to the residents of Chatham and surrounding counties. Now, to review, in part 1, we discussed the need, necessity, opportunity, and planning, or the clinical case for reintroducing safe and sustainable maternity services at Chatham Hospital. Today, we will discuss how the plan was implemented, looking at the strategies for operating sustainable services or the business case for opening a maternity care unit at Chatham Hospital. Now, we got to meet Dr. Page and Jeff in our first podcast, and I want to welcome them again today. Dr. Cristen Page is Executive Dean, UNC School of Medicine, Chapel Hill, and Jeff Strickler, President and CEO, Chatham Hospital, UNC Healthcare, Siler City. Welcome, Dr. Page and Jeff, to part 2 of our podcast, where we're going to discuss the strategies for operating a sustainable service or the business case for opening a maternity care unit at Chatham Hospital. Now, there are so many requirements that must be met in order to provide safe and sustainable maternity services, such as cost, safety, and clinicians. Now, Chatham Hospital closed its service in 1991 because it no longer had obstetricians to deliver babies. Jeff, what's different today than 30 years ago?
Well, quite frankly, as we talked about, it's the partnership with UNC Health System. I arrived with UNC Health in 2003, and soon thereafter is when Chatham Hospital became part of the developing UNC system. At that point in time, UNC Health System really consisted of just one other hospital, and then Chatham was the third hospital. And in 2008, the system built a new facility for Chatham Hospital, so it enabled it to move out of a outdate facility and into a new facility, and then also added the new business model of being a critical access hospital. So it's really only through that support that really made this possible. And we talked about the financial support, and that's significant. But it's more than just the dollars. We also just mentioned like some of the resources that we were able to tap into on the provider side of things, as well as construction support. But it really touched every area. So our accreditation department that is able to support us and make sure that we're meeting all the standards and the requirements, that we need to. And then just being part of a research-based health system, just the way we embrace innovation. And so this development of this model that's based on family physicians providing this care, and then also allowing those that are advanced providers such as CRNAs to really function at their full scope of licensure. I've often said in various conversations that although it's really exciting and a great tangible part of this project is the return of maternity services and delivering babies at Chatham Hospital, but what we're really after is both a way to recruit providers to live and work in rural communities and to build a cost sustainable model for maternity care that can then be replicated in other communities across the UNC system and really across the state of North Carolina. This model is not unique from the standpoint you can find it in other parts of the country. What's somewhat unique is that this is being done in the context of a health system, and it's unique and novel for the state of North Carolina.
Dr. Page, then how did UNC help make this happen?
Well, I think Jeff said it well, but I'd say a couple key things we did was to very deliberately and strategically tailor the model to the needs of the community and really paying attention to the sustainability factor. UNC Health was supportive of returning maternity services to Chatham in concept, but it was clear that the typical models of care that we have in our other hospitals and across rural America were not going to be financially sustainable. So we worked together with the leaders at Chatham Hospital and in the UNC Department of Family Medicine to design a model that was financially sound and took care of the whole patient. So making sure we had opportunities for Spanish-speaking providers that were thinking about family physicians and staff who can do more than one thing. When you've only got a low volume of deliveries in a hospital, it's not sustainable to pay huge salaries for a surgeon, an obstetrician, an anesthesiologist, all these different very expensive providers for low volume. So to find ways where we could be more efficient with providers who could do more than one thing using midwives and CRNAs, that was a really key part of engaging with our business leaders to think that through, to ensure that we're doing this in a more sustainable way, both in those direct costs as well as in the whole financial model for UNC Health. And with the great excitement and appetite that this could be then a model that we replicate. And we're ready. I mean, our CEO asked me the other day, where are we going next? That is really exciting.
That is very exciting. Let me take this opportunity to reference the article that you published in New England Journal of Medicine Catalyst in May of 2021. And in this, you did a tremendous job of looking at the capacity and to estimate market size for the maternity unit that you were going to develop in Chatham, and worked in your FQHC that was there as well, Piedmont FQHC. I mean, you really applied yourself to the research and the background to demonstrate the need in the county.
We did, and I'm grateful for the analysts who were willing to work with us to do that work. But various stakeholders need different parts of the puzzle, right? So we can see what's right for the patient. And some people are, if their job is to make sure it's financially sustainable, then we needed to really make the case that, look, long term, here's the catchment area, here's where these people are delivering now, here's what's happening at the medical center. Like all those different angles of the puzzle were important for us to translate the case to each person for what they understand. It's like translating different languages. And that's the piece, I think, as a physician and public health person, engaging with the community is natural. And then I happen to be more in the leadership business aspect of healthcare as well. So being able to translate that to our financial and business leaders was really an important piece of all of this.
That's terrific. And introducing maternity services increases patient volume, but it also increases staff workload. And this is going to be amplified during a medical surge like COVID-19. So, Jeff, what systems were needed, and how did you manage this volume and workflow to provide the new service?
operations of a maternity service just touch every area of the hospital. I mean, there wasn't any single department that really didn't have to have an operational plan as to how they were going to provide, services to this new unit and to this population. There was the obvious aspect of adding a new 24/7 service, and the onboarding of the providers and the nursing team. But there was also looking at how we were going to provide services ranks for this program. There was a doubling of our security staff for this program. There was additional lab testing and working with pharmacy for needs that we would have after hours when a pharmacist is here. So it truly touched every area. Perhaps one of the most significant areas that we really had to focus on was having an on-call response from our surgical team and our anesthesia team for any emergency C-sections that we would have to do. Much of our model is based upon risk stratifying the deliveries so that we minimize that occurrence. And actually, our C-section rate right now is much lower than what we had originally projected. But of course, you have to have that capability. And so working with them and making sure that we had systems in place. And as Dr. Page had mentioned, one of the challenges with this is just how do you build a lot of flexibility into your plans and with your staff, because this is a highly variable volume. I mean, there are some days when we have no patients, and then there's days where we're nearly full. And so they just have to have a lot of flexibility to go in various directions. But that was actually one of the hidden benefits of this program, particularly in the time of the pandemic. There was staff that were able to be of assistance in other areas. So if there's no maternity patients, then our staff is floated to support the emergency department, to support the inpatient area. We have been very deliberate in telling them that we're not going to put them into any kind of a situation where they don't feel like they have the competencies for that. And likewise, we prioritize their function to shift to maternity if a mother that's laboring presents itself. But it deepened our bench, I guess is the way to say it.
That's real helpful. And Dr. Page, help us a little bit then to understand from your perspective at UNC Health, this increased surgical capacity and the clinical capacity that was going to be required of Chatham Hospital. You're not just increasing volume, but now you're 24-hour on-call nurse anesthesia, you're retraining floor nurses. Where were you involved with this retraining and the increased capacity for surgical services and maternity services at UNC?
Well, Jeff described it well, and I'd say that, again, it required a whole team. My personal role was, championing this and building the case and helping launch it, but it is the people in the community, in the hospital, who are doing the lion's share of this work. And the new chair of family medicine, Margaret Helton, who has helped recruit providers very successfully to this area. There's so much excitement around it that it's been very attractive to providers, particularly family physicians with C-section training or family physicians who want to deliver babies. We've also attached an educational arm of this. So there are residents being trained in family medicine in that critical access hospital, particularly to help with those pipeline initiatives so that those new doctors are much more likely to practice either at Chatham or at another rural setting. But it's just required flexibility, dedication, and people like Andy Hannibal, a family physician who's the chief medical officer at Chatham, and Dr. Dana Iglesias, who we recruited back after she had served in Nigeria and multiple places to really focus on the mission at Chatham. She serves as the medical director of the maternity care center and has worked very closely to develop systems of care, to develop risk stratification of patients, good transfer systems, and ultimately to ensure that we're giving each patient that personalized, patient-centered maternity care that each person deserves.
And it really does make a difference when you can increase your bench strength that way and you can integrate the skills of other primary care professionals into this service so that you have the flexibility across other service areas as well. And of course, adding a new service takes money, and that's especially true of a maternity unit. So Jeff, how did you cover the cost for a maternity unit at a critical access hospital?
It was really through the support of the health system that backed us up financially with that. They covered really the construction expense. And although we often focus on that level, the investment for the construction and the equipment, there's the operating expense. And so this increased our expense for our providers. It increased expense for the nursing staff as well. And ultimately, since we're still in the ramp up period of the program, I mean, it did grow the loss that as a critical access hospital, we have sort of the bottom line on our books, although I will tell you we're outperforming that projection. So there's just, a level of tolerance of that as well. And I think part of that comes from an understanding within the health system that there's certain things that don't reflect on Chatham's books. And so there's quite a flow of patients from Chatham Hospital to the medical center that need that quaternary level of care. And so when that's factored into the equation, Chatham Hospital, even though being the smallest in the health system, still has a significant value to the system. And so I think just conversations that really looking at that end goal and what the value was is really how we were able to put together a case that enabled us to get that financial support.
Well, it's great to hear that you're exceeding your projections at this point in time. And of course, this is nothing new to those of us who have experience in healthcare in the sense that maternal care is costly, but it's an essential service. So, Dr. Page, how did UNC Health contribute to this funding of the new service? And are you pleased with the return on investment?
Jeff outlined the financial support from UNC Health, but also want to be sure to acknowledge the excitement and commitment allowed us to gain additional partners in philanthropic funding from the Duke Endowment, the Cannon Foundation, other organizations that were willing to step up, the Chatham County Health Department. In the early phases of the process, we're monitoring patient satisfaction, distance to delivery, and health outcomes. But it's too early to outline that return on investment now. For now, there's pride. There's every happy, healthy birth that happens in this facility is a return on that investment that you can't really quantify. But we also know that mothers typically are the ones to choose providers for their families. So we believe that this positive experience for moms in their own community will give a long-term benefit to the sustainability of rural hospitals. But we're tracking multiple patient-centered outcomes, financial sustainability outcomes, and we'd be delighted to share those results with you down the road.
And you hit on a point that's really important, is that by introducing the family to the hospital at the time of birth, you really develop a relationship and trust that will last the lifetime, not just of the mother, but of the child that was born there. It's great to see the broader community, philanthropists rallying behind this public health priority as well. But by adding this new service, Jeff, you also diversified your patient mix considerably. So how did you address that change, and where did you adjust there?
So as we had talked about, the local community, particular in Siler City, is a fairly diverse community. And we were already interacting with that population, particularly through our emergency department. So it really just increased our exposure and our time, the number of people that we would encounter, and really the time that we would spend with them versus a brief emergency department encounter. This was, spending a better part of a day or more interacting with patient and family. This aligned well with our efforts around Carolina Care, which is another core value of our health system, and that's really the brand of care delivery that we provide, and is really focused on the individual. We also worked very closely with our interpreter services, and that was another area where we had some expansion in services to be assured that we could communicate adequately with our patients and families. We also were really intentional in trying to recruit a diverse providers and staff that was reflective of the community in which we're serving. We were successful with that on the provider side. We've had not as much success on the nursing side, not for lack of trying. It's more really than the supply with that. But this also aligned well with efforts we were doing at Chatham Hospital in a parallel path around diversity and equity and inclusion. And so all of this just really came together and enabled us to just create a product and experience that we're all very proud of.
We were talking about when this would roll out, and you had established the target date as Labor Day of September 2020, which is really, really a fun thing. And since then, in the first 4 months, you had 45 deliveries that include 4 cesareans, all within the first 4 months. And then you were looking at a goal of at least 12 babies a month. Have you achieved that goal? Are you getting near that? What's been the experience?
We are slightly below that goal. And again, this is an impact of the pandemic. So as we know, nationally, that there's just fewer pregnancies, given the fact that economically and socially there is just a time of being unstable. But with that being said, we're up to 70 deliveries. We had our 71st is in motion this morning. It will be our 5th C-section. And it's tracking just slightly below goal, but from a broader perspective, our goal was to try to reach a break even within 3 years, and we're really, tracking reasonably well with that. We're only about 10% below the goal.
That's really great. Dr. Page, what's UNC Health's response to these kinds of numbers that you're hearing from Jeff?
We are thrilled. We are just so impressed and in awe with how the team has followed through on this commitment. Personally, very proud, but our whole health system is really proud of this, that we're being innovative. We're bringing services to a community that needs us. We're going too rural with maternity care instead of what's happening across America in the reverse direction. And hopefully we're creating this model for ourselves and other hospitals and for others across the nation. So our mission at UNC Health is to improve the health and well-being of the people of North Carolina. And this maternity care unit certainly helps us get closer to meeting that mission and is a tangible example of us following through with that mission.
This has really been a fabulous discussion. We've gotten to some really hard questions with respect to the operations and the planning for the business case of this. And I really want to thank you for being so upfront with your responses, because it does give our listening audience an idea as to how this might be replicated in their communities and with whom they have to partner when they're considering reopening a maternity service, because it is an essential service and one that's desperately needed for our moms and babies. The pathway to recovery for rural health services goes in many directions, and reintroducing maternity care is among them. Planning a strategy to launch and sustain a maternity care unit at a critical access hospital during a public health emergency is a bold and inspiring effort born not from the pandemic, but from the critical need for a scarce resource to keep moms and babies safe. The lack of maternity services is a critical public health issue that must be addressed to ensure positive outcomes for moms and babies. And it can be done. But it takes a team of dedicated, courageous partners like UNC Health, Chatham Hospital, Chatham Health Alliance, and all the other partners that were involved in this vision of the future and the motivation to break from the status quo. Again, I want to thank our expert guests, Dr. Cristen Page, Executive Dean, UNC School of Medicine, Chapel Hill, and Jeff Strickler, President and CEO, Chatham Hospital, UNC Healthcare, Siler City, for joining me today.
Thanks for having us, John.
Thank you, John.
And this has been part 2 of our 2-part podcast on rebuilding maternity care in rural North Carolina. Thank you for joining me on our Pathways to Recovery for Rural Hospitals and Health Systems. This has been an AHA Advancing Health podcast.